So today's presentation will be on Pheochromocytoma and parathyroid disorders. So I'll start off with Pheochromocytoma. So Pheochromocytoma is a rare catecholamine secreting tumor derived from the chromaffin cells. Because of excessive catecholamine secretion, it can precipitate life-threatening conditions such as hypertension or cardiac arrhythmias. Etiologically, 30% are part of hereditary syndromes, while the rest are sporadic. And the most common include VHL, multiple endocrine neoplasia, and NF type 1, neurofibromatosis type 1. So we'll start off with a small anatomy of the adrenal glands. See, adrenal glands can be broadly classified into the adrenal cortex and the medulla. And the cortex has zona glomerulosa outermost, zona fasciculata beneath that, and zona reticularis lowermost, and below that comes medulla. The hormones secreted by zona glomerulosa are mineralocorticoids such as aldosterone. Zona fasciculata secretes glucocorticoids, and zona reticularis secretes androgens, while the adrenal medulla is one secreting epinephrine and norepinephrine. Catecholamines. These are the organic amines produced by the body to serve as chemical signals for nervous system. We have epinephrine and norepinephrine, with epinephrine majority of epinephrine being secreted from the adrenal medulla, and majority of norepinephrine which are produced in the CNS and sympathetic nervous system. Fight or flight. So this is a diffuse systemic response which occurs because of catecholamines. It's mainly because of its actions on alpha and beta receptors. This will show you the actions a bit more clearly. Alpha 1 receptors cause smooth muscle contraction, which increase BP, vasoconstriction, while beta 1 causes cardiostimulation, that is increase in heart rate, increase in myocardial contractility, and beta 2 causes smooth muscle relaxation, bronchodilation, and decrease in peripheral vascular resistance. So this will broadly cause systemic vasoconstriction, increase BP, decrease heart rate, increase contractility, pupillary dilatation, bronchodilation, decreasing blood flow to non-essential organs, and inhibition of digestion. Metabolism of catecholamines occurs via two major pathways. There is a MAO and COMT, monoamine oxidase catecholomethyltransferase transferase. MAO causes deamination of norepinephrine and epinephrine to aldehydes, while COMT causes norepinephrine and epinephrine to get converted to normetanephrine and metanephrine respectively. Okay, the pathophysiology. So clinical, as I have mentioned, the clinical manifestations of pheochromocytoma occur because of excessive catecholamine secretion, stimulation of alpha receptors and beta receptors. The key thing here is that catecholamine secretion here is unregulated. So there is no, as pheochromocytomas are not innervated, catecholamine release is not precipitated by neural stimulation. So etiology I had mentioned before. Presentation. So the dominant presentation is paroxysmal hypertension. In the classical triad we see tachycardia, headache, and sweating. Sinus tachycardia is the most common cardiac rhythm abnormality that we see. So this is the signs and symptoms in the order that is like from most common to least common. The most important being paroxysmal hypertension, headaches, palpitation, hyperhidrosis, and the clinical importance of signs and symptoms, or why we should recognize these. Pheochromocytoma can have a very high mortality rate if it is not treated or identified. Hypertensive crisis is a threat to life and organs, and around 50% of the cases are malignant, and surgical resection is curative in most cases. The other acutely precipitated conditions that can occur include congestive heart failure, pulmonary edema, myocardial infarction, ventricular fibrillation, and cerebrovascular accidents. Differential diagnosis: angina pectoris, the palpitations, anxiety disorders, factitious disorder, Munchausen syndrome, hyperthyroidism, thyrotoxicosis, hypoglycemia, and PSVT. So the investigations are, these are the reasons why we should go for a pheochromocytoma suspicion. Signs or symptoms suggesting patient might have catecholamine excess, especially if it is paroxysmal, unexpected or refractory high blood pressure. Incidentaloma is a normotensive patient that you usually see. Patients with hereditary risk of pheochromocytoma, such as VHL or MEN, should also have investigations for pheochromocytoma done. The cornerstone for diagnosis is elevated levels of plasma and urine catecholamines and metanephrines. So this is a flowchart regarding the investigations for pheochromocytoma. First, we need to discontinue interfering medications. These include TCAs, phenoxybenzamine, levodopa, beta blockers, amphetamine, and methyl dopa. So once these medicines have been discontinued, and we look at the clinical suspicion, if it is the probability, if it is high, start off with fractionated metanephrines and fractionated catecholamines, and plasma fractionated metanephrines. If you see a more than twofold elevation above upper limit of urine catecholamines or urine metanephrines, we need to localize the tumor. That can be done using CT scan or an MRI. If it is typical, that is, it is either adrenal or para-aortic, we need to consider alpha and beta blockade and then surgery eventually. If it is negative, if on localization we find that it's a negative abdominal imaging, we need to reconsider the diagnosis, go for 123I MIBG scan, whole body MRI scan to see if paragangliomas might be present or not. So looking at the sensitivity and the specificity, we can see that catecholamines have a high degree of sensitivity and specificity, while fractionated metanephrines have high sensitivity while lower specificity. So a sensitivity is to rule in, while specificity is to rule out. In this way, what preferred method is catecholamines first, 24-hour urine catecholamines and fractionated metanephrines. Okay, so here fractionated
sensitivity is to
rule in.
But when you say rule in, what do you mean?
Means that it will diagnose the condition, while specificity.
Say if something is very sensitive,
yes,
but it is not very specific, then if that test is positive,
yes,
it does not mean the patient has that disorder. However, because it is very sensitive, if the test is negative, that means the patient does not have it.
Yes.
So to rule out.
Okay.
High sensitivity test, if it's negative, it rules out the condition.
Okay. Okay. So
whereas high specificity, if it is negative, but if the test is not very sensitive, then it does not rule out the disorder. So the sensitive test is to rule out.
Okay.
A specific test, if it's positive, then the person has a
yes.
It rules in the test.
Okay.
You follow me?
Yeah, I usually get confused in this. Yeah.
And this is something. Yeah, I say a classic example is SLE.
Okay.
Okay. ANF is very sensitive.
Yes.
So if you think somebody's got SLE and the ANF is negative, then by and large the patient does not have SLE. Whereas say double stranded DNA or anti-Smith is very specific for SLE. but they're not very sensitive. Their sensitivity is about 70%. So a negative anti-Smith or a negative dsDNA does not rule out SLE. But if they're positive, then the patient is, because they're very specific, they're likely to have SLE.
Okay. Okay. Yes. Yep. So norepinephrine and epinephrine, under the action of COMT, convert into normetanephrine and metanephrines, and these are free metanephrines. That is normetanephrine and metanephrine together, while fractionated metanephrines are normetanephrine and metanephrine that we are looking at the levels separately. So the medical therapy and preparation for surgery. First of all, we start off with alpha blockers, that is phenoxybenzamine. It is the most commonly used method of alpha blockage. We need to keep giving this medication till we find that the alpha blockade is complete, or side effects such as postural hypotension occur. Beta blocker therapy is started after that. Propranolol 10 mg TDS is given for adequate beta blockage. Metyrosine inhibits tyrosine hydroxylase. That is the rate limiting step in catecholamine biosynthesis, and it also significantly reduces catecholamine stores. So it makes pre and post op blood pressure control easier. During surgery, IV phentolamine can be given. It's a rapid acting alpha antagonist, and rapidly acting beta blockers, esmolol, can also be given.
So do you have an agent which can do the job of both the alpha blocker, beta blocker?
Labetalol can do both alpha and beta
And
blockers.
it can be given orally and it
Yes,
can be given.
yes, yes.
So it's a
Yes.
We generally don't use it that much because it's very little alpha.
okay.
This is very little alpha blocking.
Yes.
What is really required is good alpha blocking.
Yes.
So what is the sequence? You really want to say somebody you've seen the diagnosis of Pheochromocytoma. First you block alpha.
Yes.
Why?
Or else hypertensive crisis can occur.
Yeah. So if you give beta blocker, you're going to
Unopposed.
circulate.
Yes.
So once you block alpha, then what is the next thing you need?
Then we block beta.
No.
No?
That's the very important thing. Then somewhere in between comes that you have to basically make sure that he's got adequate IV fluid status.
Yes,
Fluid
yes,
status.
yes.
Because they can get postural hypertension just because they are hypovolemic.
Yes.
Now that you have managed to dilate the blood vessels, you actually need more fluid. Okay, so
Yes.
what you really want is a fluid fill them. Once you fluid fill them, now you beta block it.
Yes.
Okay, so that if you do that, then you're perhaps much more sure stepping the way you're treating pheochromocytoma.
Yes. So surgery. So most of these days, laparoscopy has replaced laparotomy as the procedure of choice for surgical correction, and most of them, less than 6 centimeters, we undergo laparoscopy. Post-op management is the issues include post-op hypotension. This can be especially high if we are giving medicines such as metyrosine and phenoxybenzamine, which were given pre-operatively. Volume replacement is a treatment of choice to prevent post-op hypotension. So you need to give large amounts of fluid. Post-op hypotension may also be related to volume overload or autonomic instability, hypertension, autonomic instability or essential hypertension, or in the worst case scenario, a residual tumor. So we will start off with a case. Case 1 is the music teacher. The history of presenting illnesses: a 30-year-old female music teacher presented with complaints of dyspnea, headache, tachycardia and vomiting. These attacks are paroxysmal and have been increasing in frequency over the past year and a half. During the attack, she is prostrate with discomfort. On hospital admission, physical examination revealed a pale and undernourished woman, but otherwise physical examination was normal. Heart rate was normal, blood pressure is also normal, CBC is normal. Other studies including EKGs, chest X-ray, abdominal X-ray were all normal. Shortly after admission, the patient develops tachycardia, BP becomes 280 over 180, chest pain, headache, nausea, vomiting, blurry vision, and numb extremities follow. Now again EKG is repeated. Tachycardia, BP is again 300 by 180.
How did they measure that?
Due to severe hypertension and intractable abdominal pain, an exploratory laparotomy was performed. So this was the case that was published by Charles Mayo in 1927. So at this point of time, there was no pheochromocytoma diagnosed as yet. There was no biomedical lab tests for pheochromocytoma, no CT scans or MRI, and no idea how to control blood pressure before and during surgery. I couldn't find more about this case, but like the little bit I could find was this. So case number 2 is an inherited syndrome. A 45-year-old female with neurofibromatosis type 1 and severe kyphoscoliosis presents with palpitations, rapid heart rate, and persistent headache. So she's on Ritalin, that is for ADD, and methadone. Symptoms have been attributed to Ritalin. Past medical history has a remote history of stroke 23 years ago, dizziness and palpitation for years. A biopsy of the thyroid nodule was shown to be benign. CT scan that was performed revealed a right adrenal mass thought to be likely a neurofibroma. Family history of multiple relatives, first degree relatives who died from complications of neurofibromatosis. One. She is unable to tolerate an MRI and a CT scan is done. A 6 by 2 centimeter mass of pheochromocytoma, believed to be pheochromocytoma, is seen. 24-hour urine fractionated metanephrine disorder, and urine metanephrine and norepinephrine, both of them come high. Now patient is scheduled for surgery at systolic blood pressure is 120 at admission. Alpha blockade was started 10 days pre-op, that is phenoxybenzamine. Beta blockade was started after a week of alpha blockade with propranolol. And a transperitoneal right robotic adrenectomy was planned. Studies show that this has been a better choice these days because the complications are lesser and the trauma is also better. Attempted right robotic laparoscopic adrenalectomy is aborted. Dense additions and poor access to retroperitoneum due to liver anatomy. So they scrubbed in again and converted to a flank adrenalectomy. Here we excised 11th and 12th ribs and the tumor is dissected. So this is how the tumor looks. So summary, pheochromocytoma is a tumor of chromaffin cells of the adrenal medulla. Classic presentation is tachycardia, headache and sweating. The dominant sign we see is hypertension, and this is paroxysmal. Most are curable, deadly if they are not identified. Recommended testing is plasma-free metanephrines or urinary fractionated metanephrines. So the next topic is parathyroid disorders. So the introduction is there are 4 parathyroid glands present on the posterior aspect of the thyroid gland. They secrete parathormone, which is the principal method of regulation of calcium levels in the blood. Development, we see that the parathyroid glands develop from the endoderm of the 3rd and 4th pharyngeal pouches. The inferior ones develop from the dorsal part of the 3rd pharyngeal pouch and the superior ones from the 4th pharyngeal pouch. Parathyroid hormones and the effect and the regulation of calcium. I will summarize this in a photo. So parathormone, it acts on calcium. It is the principal regulator of calcium levels in the body. It increases calcium levels, decreases phosphate levels. It stimulates the formation of active vitamin D in the PCT of the kidney, which then causes absorption of calcium from the urine in the DCT and the loop of Henle. The activated vitamin D also acts on the intestines and increases uptake of calcium from the intestines. Vitamin D itself, like I said, calcium uptake from the intestines and from the distal convoluted tubule. Calcitonin has low physiological importance in humans, but what it does is it increases calciuria, decreases uptake of calcium in the GI tract and reduces bone resorption. Fibroblast growth factor 23, its main function is to increase phosphaturia and reduce phosphate levels. Now for homeostasis of parathormone and calcium levels. So once calcium levels fall, it stimulates the parathyroid glands, which causes PTH secretion. PTH acts on the osteoclasts, which increases the serum calcium levels. Also acts on the kidneys, because the activation of vitamin D, which increases calcium absorption from urine and also from intestines. Once calcium levels are high enough, this calcium levels cause negative feedback for the parathyroid glands, and also the thyroid glands themselves secrete calcitonin, which increases calciuria, also causes osteoblast activity to increase, which deposits calcium levels into the bone. This is calcium homeostasis just in a picture format. This is formation of vitamin D, from 7D hydrocholesterol to vitamin D3. The liver plays a role here with 25-dehydroxylase enzyme. It gets converted to 25-cholecalciferol, and then vitamin D converts along with 1-alpha hydroxylates, converts 25-calcidiol to calcitriol. And calcitriol acts on the PCT and the intestines to increase calcium levels. Now, disorders of parathyroid can be classified broadly into hyperthyroidism and hypothyroidism. In hyperparathyroidism, we can classify them into three types: primary, secondary, and tertiary. Primary hyperparathyroidism is a disproportionately high secretion of parathormone, even with high calcium levels. So what we see is parathormone levels that are increased or normal, calcium levels which are increased, but with reduced phosphate levels. Secondary hyperparathyroidism shows again disproportionately high parathormone secretion with calcium concentration. Most common cause is CKD, because there is inability to produce the calcitriol. Here again we see parathormone increased, calcium normal or reduced, but again reduced phosphate levels. Tertiary is an autonomous secretion of parathormone, especially after long periods of secondary hyperparathyroidism. We usually see this in CKD patients after years of dialysis. We will start off with primary hyperparathyroidism. There is an abnormal secretion of parathormone which causes hypercalcemia. This hypercalcemia in turn fails to inhibit PTH secretion, and an increase in calcium levels and decrease in phosphate levels are seen. Around 85% are caused by parathyroid adenomas, 15% diffuse parathyroid hyperplasia, and less than 1% is parathyroid carcinoma. The prevalence increases dramatically after the age of 50 and is present 2 to 4 times more in women compared to men. So a broad description of the signs and symptoms of hyperparathyroidism. What we see is osteopenia, osteoporosis because of bone destruction, fractures because again fragility, hypercalcemia, you can see pancreatitis, polydipsia, polyuria, cardiovascular features, hypertension, arrhythmia, ventricular hypertrophy, weakness, parathyroid crisis. And hypercalciuria, you will see nephrocalcinosis, and urolithiasis. So this is a picture showing all of the complications that can occur, including like the rarer ones. ECG changes that we see in hypercalcemia. The main one that is seen is the shortening of the QT interval with Osborn waves that may be seen, also called J waves. Ventricular irritability and fibrillation arrest have also been reported with extreme hypercalcemia. Now, differential diagnosis can be classified into parathyroid related or vitamin D related. Primary hyperparathyroidism, lithium therapy, or familial hypocalciuric hypercalcemia. So FHH is a condition in which familial hypercalciuric hypercalcemia, where the calcium receptors in the parathyroid are defective, which causes increased secretion of parathormone and therefore hypercalcemia. Vitamin D related is sarcoidosis, granuloma because of increased calcitriol, vitamin D toxicity, and idiopathic hypercalcemia of infancy. Malignancy is solid tumors. High bone turnover rates can be seen with hyperthyroidism, immobilization, and thiazides, vitamin A intoxication. And lastly, associated with renal failures is severe secondary hyperparathyroidism, aluminium intoxication, and milk alkali syndrome. Now, lab tests. So we will see that there will be an increase in calcium, an increase in parathormone, reduction in phosphate levels, normal or reduced vitamin D, increased ALP, creatine can be normal or increased. Calciuria will 24-hour urine collection, calciuria shall be seen, creatine excretion shall be normal. We'll explain about these images later on of a better image. Now, treatment includes IV hydration. We need to adequately reduce sodium levels by giving large amounts of fluid. Apart from that, we can give calcium mimetics or bisphosphonates, but surgery is the mainstay of treatment. We need to identify and remove the enlarged tumors, either the adenoma or the multiple glandular tumors. So calcium mimetics that are given, these reduce calcemia and calciuria. They can reduce PTH, but do not affect bone marrow density. What was this?
Bone mineral density.
Bone mineral density. Sorry. Bisphosphonates increase bone mineral density, but do not affect serum calcium. And denosumab is a Rankle antagonist which decreases bone resorption. Parathyroid crisis is a rare disease characterized by severe hypercalcemia with serum calcium concentration usually above 15 mg per dl and marked symptoms of hypercalcemia. So what we see is dehydration that shows hypercalciuria, CNS dysfunction, confusion, days, nausea and vomiting, constipation, bradycardia, ECG waves will show QT shortening, and palliative ileus. So treatment is similar. We need hydration with large amount of normal saline, furosemide, bisphosphonates, calcitonin, and calcium mimetics. Now, surgical consideration in asymptomatic patients. So when do we go for surgery? So calcium levels more than 1 mg per dl above normal, reduced bone mineral density, that is T-score less than 2.5, that is in osteoporosis. Renal, we'll see creatinine clearance less than 60, and urine calcium more than 400 mg per day. Nephrolithiasis or nephrocalcinosis seen on CT and less than 50 years of age. Secondary hyperparathyroidism. So there is an increase in PTH due to chronic stimulation of the parathyroid glands because of chronic decrease in the ionic calcium levels. The kidney is responsible for vitamin D activation, and with decreased functioning of the kidney, this pathway does not work properly, causes reduced absorption of calcium from the blood and from the urine itself. So treatment involves reversing the cause of the kidney disease, so that will cure this. But in case the disease is not cured, it will eventually move into tertiary hyperparathyroidism, where there is an excessive secretion of parathormone even after long-standing secondary hyperparathyroidism. So here there is an autonomous secretion of parathormone, mainly seen in patients with chronic secondary hyperparathyroidism who have been on dialysis therapy for years. So this is a dangerous condition, and this should, all efforts need to be taken to stop this from developing. Now to come on to hypothyroidism. This is deficient hypoparathyroidism, yes. Deficient secretion of parathormone, which manifests itself biochemically by hypocalcemia, hyperphosphatemia. So it can be either acquired, removal of the gland itself during thyroidectomy, or interruption of blood supply to the gland, which is the most common, autoimmune, congenital, or familial. Clinical features, the most common include paresthesia, tetany, hyperventilation, convulsion, and signs of latent tetany, Chostek syndrome and Trousseau syndrome. Chostek sign and Trousseau sign. Can also cause post-lenticular cataract, and here in the ECG we can see an increase in the QT interval. Hypotension, refractory heart failure.
So what is Chostek sign and Trousseau sign?
So Chostek sign is increased irritability of the facial nerve. So on tapping your facial nerve, it causes spasms of the muscles. And Trousseau sign is on inflating the blood pressure cuff over your brachial. It causes the movement, the spasm of the wrist joint. Yeah. Huh? Carpopedal spasm. Carpopedal spasm.
That's what I'm saying.
Why is it?
Because the same thing can happen with the life.
Oh.
You have to inflate the BP cuff, you have to leave it for a little while, and they go like this or.
Yes, yes. So treatment is in the absence of renal failure and the presence of hypocalcemia with hyperphosphatemia is virtually diagnostic of hypoparathyroidism, and undetectable serum PTH will confirm this. The mainstay is combination of oral calcium with pharmacological doses of vitamin D or its analog. Treatment in acute severe cases will involve parenteral calcium infusion of 100 mg over 10 to 20 minutes. And in case this also does not fail to alleviate the clinical manifestations, 100 mg per hour of elemental calcium can be infused with close monitoring. Now, pseudo-hyperparathyroidism and pseudo-hypoparathyroidism. Pseudo-hypoparathyroidism has normal renal function. Resistance to the action of parathyroid hormone will be seen, and there is hypocalcemia along with an unusual constellation of skeletal defects, collectively termed Albright hereditary osteodystrophy. This is how it looks. The patient is short, obese, round faces, mental retardation, and a characteristic dimple will be seen, especially between the 4th and 5th metacarpals. Then there is pseudo-hypoparathyroidism, which is the normocalcemic variant of pseudo-hypoparathyroidism. This is caused by a genetically inherited gene, GNAS. So, now we'll discuss a case. The farmer, the 60-year-old female presented with a complaint of a mass in her neck. On a detailed history taking, it was shown to be present for over 10 years while increasing in size gradually. Other complaints she had were chronic bone pain. Now, on physical examination, we found that all her vitals were normal and just a mass was felt on the left side of the neck, around 4 centimeters broad, soft smooth and moved with deglutition. Investigation showed generally normal trend except for a parathormone levels which were 129 and calcium levels which were also increased. So an FNEC was done and a benign follicular nodule was seen. Of the benign follicular nodule, ultrasound was done, which is the center one, and you see hypoechogenic mass is present. CT of the whole abdomen, neck and chest were also done. The leftmost image is a CT which shows a mass in the left-sided posterior thyroid region, and the rightmost image shows opaque densities present inside the kidneys. So that is pointing towards nephrocalcinosis. This is the plain X-ray. On the skull, it's not visible clearly, but there is salt and pepper appearance can be seen on the skull. On the hands, you can also see osteolytic lesions on the right index finger, and calcium deposits can be minutely made out on the rightmost image. Not very clear. So that was
Good. Usually they don't present with swelling in the neck.
No, you don't.
Perhaps maybe in the past they used to, but since the advent of technology and routine biochemistry for lots of patients, although calcium metabolism the knowledge has exploded since in the US they started doing a battery of tests for anybody who comes into hospital. So similar thing with thyroid disorders as well. You just do TFT in every admission, you do a calcium and phosphate in every admission, then you will find these patients with sort of hypercalcemia, hypocalcemia, because they generally present with some of the other medical disorders and the symptoms and signs. So it's very difficult to basically pinpoint unless you have a calcium value or you have a thyroid function test value. So generally don't find a nodule. So you may get a hypercalcemia. So always when you check calcium, check
Corrected calcium.
that's fine. Check phosphate and magnesium. Why is that? Why do you need to check magnesium?
Hypocalcemia may also occur due to hypomagnesemia.
How does hypomagnesemia produce hypocalcemia?
Similar bivalent cation they share some receptor.
Because for the PTH to work, parathormone to work, you need magnesium. So the PTH will not be effective if you are hypomagnesium. So how would you treat somebody with hypercalcemia? Calcium of 14, say.
Start with hydration, intravenous hydration. Then give bisphosphonates will be given. Usually hydration reduces the levels a little bit. Furosemide you need to give, calcium mimetics, and steroids, glucocorticoids.
Give it to everybody. You give everything to everybody.
No. No, but more than like 14.
We will check the phosphate level. Then we will try to assume means what may be the etiology, whether it is means whether primary hyperparathyroidism is there or not. Or means usually means in hypercalcemia, if parathyroid function is normal, there will be primary hypoparathyroidism.
See, you're a hospital where malignancy oncology is a big number of patients. You get somebody with hypercalcemia, you can send their calcium, send their phosphate, send their PTH, send their magnesium values. and then you perhaps want to treat it. So what treatment do you normally would give? Because the reports will come after maybe a week or so, or 5 days at least.
One thing is hydration, so one thing is
So you give hydration.
If it is severe
What will you give
hypertension,
as a hydration?
that is some solutions. Ringer lactate या plasma
Normal saline, এই তো স্লাইডিং তো লেখা আছে কেন সেলাইন দিতে হবে কেন
others contain to some extent calcium, calcium acetate calcium.
না না নর্মাল সেলাইন দিতে হবে কেন if you give sodium load salt load what happens
Sure. Diuresis of it.
diuresis of it because calcium will be exchanged as a consequence so you get calciuresis if you give a sodium that's the reason why it is categorically stated that you have to give normal saline saline dile tapore
Then diuretics such as furosemide
furosemide keno
to more diuresis.
and more sodium
Yes.
more calciuria that's the whole idea yeah so next
Then calcium mimetics are given.
calciumatic
That are in the class, but glucocorticoids.
you can do that although what is normally generally preferred you give a bisphosphonate
Bisphosphonate. Bisphosphonate. Yes.
so you give a bisphosphonate calciumatic is something which is generally would be used in the OPD okay for mild hypercalcemia so in your ICU you will give a bisphosphonate
Yes. Yes.
and you may perhaps want to give also glucocorticoid, but these days you don't do that. You have given more effective medicine, which you mentioned.
Denosumab.
That's what you've seen is being done. This is what it is. This is what you have to do. So how quickly will the calcium come down? তুমি দিলে হ্যাঁ bisphosphonate to দিলে which bisphosphonate you want to give?
IV. Solid.
That's what the oncologists prefer. But if you really want it to work faster, amytronic acid is the much more faster acting. Zoledronic acid দিলে calcium কখন কমবে? মিনিমাম 2-3 দিন লাগে আর বেশি দিন লাগে তুমি রোজ চেক করছো কমছে না চেক করো কমছে না তুমি তো ক্রিটিক্যাল কেয়ারে আছো না তোমার মধ্যে কমছে না তারা অন্য কিছু করবে দিস ইজ হাউ ইট ইজ so if you know when it works so if you give amytronic acid to work by next day you find that perhaps it's coming down the saline the diuresis it will work and then you give amytronic acid but sometimes the oncologists they prefer zoledronic acid it's part and parcel of their oncotherapy that they do. So that's how it is. And they give, recently we had a patient in hematology with a light chain myeloma with a calcium of I think something like 16 or whatever it was, 15. And they give denosumab as well. The calcium came down but it was a light chain myeloma. But because it's the but anyway, I presume it's the underlying illness is such that because he had cervical sort of spine, I think C1 or C2 lytic lesions, so, and he had developed a fracture there. So you die of that, perhaps you don't die of the hypercalcemia like everything else. So you can give denosumab also works very fast. Yeah. Suppose the patient is in renal failure, which actually this patient was, the light chain myeloma. He also had a creatinine which is this is about a month or two ago. So suppose somebody has got renal failure, now what do we do? Low urine output.
have to go for dialysis.
Yeah, because bisphosphonates are contraindicated. Denosumab you may be able to use it, but there are certain reports saying that perhaps also it's not that safe, but maybe you can perhaps use it. But yeah, dialysis. Obviously, you can't give them saline and frusemide. There's not going to work.
Calcitonin is role in these patients.
It's very basic role. It is largely, when we use calcitonin,
Phosphate, no, sorry.
see, even the mild hypercalcemias we use calcitonin, because it has some advantage in terms of lowering calcium. Two, it has advantages in terms of these patients have say bone pain or whatever, it reduces bone pain. These are like their fractures, they have less pain as a consequence of that. So we absolutely do that. So we use it. But largely it is used subcut variety, it's 100 milligram one which is used. But in clinical practice, mostly we are using the spray, and we are using the spray in which groups of patients? These are OPD patients who have perhaps fractures and have bone pain, so you have to use calcium. Good, yeah. So how do you correct calcium levels?
We can start giving by oral calciums or vitamin.
Corrected calcium. We always talk about corrected calcium. What's the correction? What do you want to know?
Corrected calcium.
How do I calculate?
Yeah. What else do you want to know apart from calcium to correct the calcium level?
Albumin, because it's fine.
Same formula
Formula here.
4 plus 0.8 serum calcium plus 0.8 into 4 minus 7 alcohol.
It's a model I have to mushkil tha na. You have to have an easier way to do it.
So, which is like 2 times the
See, to medicine rock. Though thankfully we are blessed with modern technology now, and perhaps it will become 5G, so it will be even faster. And your speaker is saying something, and before you finish your slide, he will perhaps get the information because of 5G. The way we used to remember it is roughly the correction value is about 0.8 or 1. Right? For every albumin 1 gram reduction or something else, you just multiply by 0.8, just change it. It's easier that way, rather than doing all these difficult ways of doing it. So if you have an albumin of 2.5, if you want 3 points, so 1 down. So whatever your value, just add 0.8 or 1, that's it. That should be enough. You can use a much more appropriate formula if you want to, but you come to a reasonable that kind of value. CC করতে পারবেন সব কিছু পেশেন্ট দেখতে যাবে না এই সব করে দেখতেই থাকবেন ক্যালকুলেশন Good. Okay. Mone rakha, that's the important part. It's always easy because you read it last night. না 7 দিন পরে জিজ্ঞেস করলে তুই ভুলে গেছিস exactly what is going to happen to all of us, not only you.
Only thing I want to say is more of a medicine thing than a critical care thing. That lately there's been this great push with vitamin D preparations and calcium preparations, and people are consuming huge amounts of calcium. বাড়িতে সবাই একটা করে এমনি খায় অর্ডেক্সের মতো, যে জিপির কাছে ফিজিশিয়ানের কাছে গেলে তারাও একটা ক্যালসিয়াম লিখে দেয় আমাদের পার্সে। অর্থোপেডিকের কাছে গেলে তো they prescribe those high dose varieties, 60K নাম আছে। So you can get patients who don't have malignancy, don't have mother due to the excessive vitamin D And when we are a patient, the government programs a vitamin D guy, it is an injection in Araki soil. It's a fat soluble thing. So একটা quack দেখে ওই ইনজেকশনটা একবার দিলে কয়েক মাস কাজ করে নাকি ওকে 7 দিনে 7টা ইনজেকশন দিয়েছে there's a lady who came in a drowsy state tried as a crisp but we found the calcium was 130 all she needed was
6 lakh units is roughly for one whole year. But I've seen people giving it weekly, monthly. The only good thing about it is that it has a huge therapeutic window. So to try and get toxicity, but presumably if you do it every day, you're going to get so you can get away with it. But one shot a year, that is good enough. Because you get 60,000, 60k, so multiply by 10, that is 6 lakhs. So that's for the year it will suffice.
okay
Good, yeah. So you do calcium, bone metabolism, and this kind of thing. You have a whole new branch of medicine where in the West they have people who do this only for their whole life. That's all it is.
endocrinology শেষ না কি বিকল্প
Yes, sir.
so what happened next
Started
toxicology anything specific next week
general approach to patient.
ফ্যাট আছে স্যার আমাদের
বলুন।
ফ্যাট এক্সাম আছে
ও বললে কবে কবে আছে
ওটা আমরা ডিসকাস করেছি।
সব ব্যাচের তো হবে না
স্যার আমাদের আছে স্যার
There's only toxicology.
Statistics doctor.
Statistics, I think, should have a classroom teaching rather than more of a seminar.
This class.